So 33-year-old young male individual, breathlessness on exertion for just 3 months, found to have a LVEF of 25%, normal coronaries, and no history of drug abuse. The only thing on investigations was that he had a eosinophilia of around 11 to 20%. And when we look at the ECG, there were some Q waves and ST segment elevations and ST segment depressions. So, how do I move this? So as we can see that there is increased right ventricular free wall thickness, increase in the septal and the posterior wall thickness, and global reduced global contractility. And the same thing is seen in the apical 4-chamber view. So the walls are thickened. So when we did an endomyocardial biopsy, it showed a granulomatous inflammation with a few giant cells, and there was a doubt of fungal spores. So on a specific stain, fungal hyphae was seen. And on the workup, what was seen was that the beta-glucan levels were high, IgE levels were high, and absolute eosinophil count was high. And when we look at the MRI, we can see that there is global RV and LV thickening, and there is late gadolinium enhancement, which is both subendocardial as well as transmural in some areas. So the molecular PCR showed Aspergillus flavus. So why did a person develop a fungal myocarditis? So we did a flow cytometry, and what was seen was that there was a reduced number of Th17 cells, and the STAT3 phosphorylation status showed that there was reduction in the STAT3 phosphorylation. So what it indicates is that this is a hyper IgE syndrome. So there is a fungus in the heart, there is eosinophilia, increased IgE level, decreased STAT3 proteins, and decreased Th17 cell response. So invasive aspergillosis, so it was a fungal cardiomyopathy with severe systolic dysfunction and a possible hyper IgE syndrome, treated with voriconazole for 1 year, almost 2 years now, and low dose of prednisolone, which was stopped after 3 months. And in addition to that, he received standard heart failure therapy. As we can see, his ECG has improved, it's come back to normal, and the left ventricular function, move this, has also improved. It's come close to normal. So the second patient that I will show is an 18-year-old boy, again a 3-month history, no history of fever, rapidly progressed to NYHA class 3, but again when we see there is an immunological aspect to it. He was noted to have diabetes, IDDM at 5 months of age that reversed by 2 years, and he was also known to have gluten sensitivity. So he had 2 episodes of transient loss of consciousness, he was in heart failure, and on evaluation he had high transglutaminase antibodies, endoscopy showed gastritis and villus atrophy. And as we can see that there is severe biventricular dysfunction, and the right ventricle is affected much more than the left ventricle. In this, again we see that there is enhancement of the right ventricular wall, and the PET CT showed again the right ventricular wall is much more affected. In addition to that, he had a ring enhancing lesion in the hippocampus. So based on all the features, the mediastinal lymph nodes, we considered this to be a possible tuberculosis. We didn't get a hard diagnosis of tuberculosis because the biopsy did not show tuberculosis. The endomyocardial biopsy just showed a granulomatous inflammation. He was put on ATT and a very short course of steroids, after which he became asymptomatic. The ejection fraction improved. However, the right atrium and the right ventricle remained dilated, and he was left with a severe tricuspid regurgitation. So just to summarize, in any case of myocarditis, it's important to do an endomyocardial biopsy because we may get a specific diagnosis. Unexpected intruder in an unexpected host, always suspect immunodeficiency, and it is very important to work when we are looking at myocarditis. Many of these patients have immunological problems. It's important to work closely with the immunologist. I mean, we should not work alone as cardiologists. And second thing is that tuberculosis is still prevalent, and tubercular myocarditis can still be seen in today's era. Thank you.